Good afternoon, everyone.
Good afternoon.
I'm giving it just a moment for a few more to connect, and we will get started in just one more minute. Good afternoon, everyone. Welcome, and thank you for joining us today for the CRCR Certification Series course. My name is Cassandra Lage, and I'm a member of the HFMA Certification Committee. I work for the Sylvester Comprehensive Cancer Center, which is part of the University of Miami Health System, as an executive director of patient access, and I've been with them for 16 years. I earned my MBA from the University of Miami, as well as my undergraduate degree, my Lean Six Sigma Green Belt, and Champion Belts. I also hold HFMA CHFP certification, and I'd like to review a few of the housekeeping rules. Be sure to complete the online coursework along with attending these sessions. Please know that attending these sessions alone will not result in sufficient preparation for the exam. The sessions being recorded and will be available on the Florida HFMA YouTube channel. Therefore, I ask that you please remain on mute and have your camera off during the session. You may ask questions during the session by utilizing the chat feature, and you may also ask questions at the end of the session. You just turn on your camera and unmute yourself and ask any questions that you may have at that time. During today's section, we will be reviewing sections 2.4 through 2.7 of Unit 2, which focuses on pre-service functions. These are critical to get right due to potential negative impacts we would have downstream processes. In this section, we'll discuss the basic billing rules for the major health plans, an overview of basis billing features and benefits, and minor claim payers and plans. Many people under the age of 65 receive health insurance through an employer. Others buy their own insurance through the individual insurance market or the insurance marketplace, also known as insurance exchange, created by the Affordable Care Act. In addition, there are federal and state health insurance programs available to qualifying individuals. For example, Medicare, it's a government-sponsored program, which is financed through taxes and general revenue funds. Medicaid is a federally aided but state-operated program that helps provide health and long-term care coverage for low-income individuals and families. Tricare, which is formerly known as Champus, is the healthcare program of the United States Department of Defense Military Health System. And Indian Health Services, or IHS, is an agency within the Department of Health and Human Services, which is responsible for providing federal health services to Native Americans. Blue Cross and Blue Shield brands are the nation's oldest and largest family of health benefit companies, and the most recognized brands in the health insurance industry. We also have commercial indemnity plans, which you don't see too many of any longer, and they cover almost all services without authorization requirements. They're self-funded plans where the cost of medical care are borne by the employer on a pay-as-you-go basis. And comprehensive health plans that attempt to reduce cost through contractual agreements with providers and through care management initiatives. Medicare insurance program has features unique from other health plans. It is government sponsored and financed through taxes and general revenue funds. Medicare Part A benefits provide coverage for inpatient hospital services, skilled nursing care, and home health care. Medicare Part B benefits are available for outpatient and professional service coverage, but the beneficiary must pay a monthly premium for the additional coverage. Medicare Part C, known as a Medicare Advantage, is a type of managed care plan that includes both Medicare Part A and B benefits and may also include Part D benefits, which leads us to Medicare Part D, which is known as a prescription drug coverage program. It consists of private insurance plans that are reimbursed by the Centers for Medicare and Medicaid Services, or CMS, for benefits provided to Medicare beneficiaries. Beneficiaries may enroll in a prescription drug plan or in a Medicare Advantage plan, which is the Part C, which may also include the drug benefit. Medicare Part A benefits consist of benefit periods. The beneficiary remains in the same benefit period until he or she is hospitalization free and or skilled nursing care free for 60 consecutive days. A deductible is due each time a beneficiary is readmitted after remaining hospitalization free and or skilled nursing care free for 60 consecutive days. Medicare uses the concept of full coverage period for payment. It will pay full benefits for up to 60 days in a benefit period. The full days, which are 60, renew with each new benefit period. After the 60 full days are used, the beneficiary has 30 coinsurance days. When a beneficiary uses coinsurance days, a daily out-of-pocket expense equal to 25% of the current deductible amount is due from the patient. After the 60 full and 30 coinsurance days are used, the beneficiary may opt to use 60 lifetime reserve days, and that's abbreviated by LTR. The daily out-of-pocket for each LTR day used is 50% of the current deductible amount. LTR days are used a lifetime and they never renew. After 60 full coverage days, 30 coinsurance days, and 60 LTR days are used, the beneficiary qualifies for no further Part A benefits. If the patient has Part B coverage, Part B can be billed for services covered in an outpatient environment. Medicare Part B is financed through beneficiary premiums and general revenues. It provides coverage for physician services, outpatient services, and other health professions. Medicare Part B has an annual deductible, and the beneficiary is responsible for a coinsurance payment for all Part B covered services, excluding diagnostic laboratory services. Coinsurance amounts for services paid under the Outpatient Prospective Payment System, or OPPS, are determined by federal regulations and change as the OPPS payment system is updated each year by CMS. Hospital inpatient and outpatient services are submitted to Medicare and Medicaid Advantage plans electronically using 837I forms or UB04 paper forms. Physician services are submitted electronically using 837P formats or CMS 1500 paper forms. And claim form requirements and edits and EDIs are covered in sections 3.5 of this course, so you'll get more details on those. To be eligible for Medicare reimbursement, claims must be filed within 1 calendar year of the date of service. Medicare systems will reject or deny claims that are not received within the specified time requirements. Medicare Advantage plan claims must be filed within the specific health plan's qualifying time limit per the provider contract. Medicaid is a federally aided, state-operated, and administered program to provide health and long-term care coverage for low-income individuals and families. A state may elect to contract with other health plans to offer one or more Medicaid managed care plans as an alternative to traditional Medicaid coverage. And that's the case in Florida. Eligibility for Medicaid benefits expanded effective January 1st of 2014 through a provision of the Patient Protection and Affordability Care Act, as states were provided additional funding if benefits were extended to individuals under 65 years of age with incomes up to 133% of the federal poverty level. In addition, for the first time, Low-income adults without children are guaranteed coverage through Medicaid. Not every state has elected to expand Medicaid coverage in this manner. To participate in Medicaid, federal law requires states to cover certain groups of individuals. Low-income families, qualified pregnant women and children, and individuals receiving supplemental security income are examples of mandatory eligibility groups. States have additional options for coverage and may choose to cover other groups, such as individuals receiving home and community-based services and children in foster care who are not otherwise eligible. Tricare, formerly known as CHAMPUS, is the Uniform Services Healthcare Program for active duty service members and their families, retired service members and their families, and members of the National Guard and Reserve and their families, survivors, and others who are eligible. Tricare Prime, an HMO type of program where military treatment facilities are the principal source of healthcare with a point of service or a POS option. This program covers active duty military and their families. Tricare Standard and Extra A fee-for-service plans available to non-active duty beneficiaries throughout the United States. This program includes outpatient deductibles and coinsurance requirements. The type of provider seen determines which option is used. When visiting a non-network provider, the standard option is used. The extra option is used when visiting a network provider. The Tricare supplement to the Medicare program. This program is only available to Medicare eligible individuals who are also enrolled in Medicare Part A and Part B benefits. And as we wrap up this section, I'd like to review some of the key points. Major health plans include Medicare, Medicaid, and Tricare. Medicare is a government-funded program which is financed through taxes and general revenue funds. Medicaid is a federally aided, state-operated, and administered program to provide health and long-term care coverage for low-income individuals or families. Tricare, formerly known as the CHAMPUS, is the Uniformed Services Healthcare Program. And this brings us to our first polling question. I really encourage you to answer the question, even if you're not sure. It's a great way of really remembering these. And our question is, which option is a federally aided state program for health coverage? Looks like everyone entered their answers. So we'll go ahead and share the results. And so we are split between A and C. And the correct answer is C. Medicaid is for low-income individuals or families. Eligibility for Medicaid benefits expand effective January 1st of 2014 through a provision of the Patient Protection and Affordable Care Act. As states were provided additional funding if benefits were extended to individuals under 65 years of age with incomes up to 133% of the federal poverty level. This brings us to section 2.5. In this section, we will address the various types of managed care and health plans and the requirements for managed care health plans. Today, more than half of Americans who have health insurance are enrolled in some kind of managed care plan. Managed care plans have agreements with certain doctors, hospitals, and healthcare providers to give a range of services to the plan members at a reduced cost. These plans usually include provisions for utilization controls such as pre-certification for admissions and high-dollar outpatient procedures. So we've got listed here some of the types of managed care plans, and I'm going to review some of the definitions. The HMOs are any healthcare insurance plan that provides or insures comprehensive health maintenance and treatment services for an enrolled group of persons based on a monthly fee. HMOs will give the beneficiary a list of doctors from whom to choose a primary care physician. This doctor coordinates the beneficiary's care, which means that generally the beneficiary must contact him or her to be referred to a specialist or obtain prior authorization for non-emergency hospital services. Under an HMO contract, the plan only covers approved services provided by HMO providers. If the patient goes outside the HMO, the patient is responsible for total charges. Preferred provider organizations, or PPOs. This form of patient care is the closest to an indemnity plan. It is a health plan where the employer and the health insurance carrier contract to purchase health services for covered beneficiaries from a selected group of participating providers. Participating providers agree to abide by utilization management and other procedures implemented by the PPO and agree to accept the PPO's reimbursement structure and payment levels. PPO coverage permits members to use non-PPO providers, although higher levels of co-insurance and/or deductible routinely apply when services are provided by non-participating providers. Exclusive provider organizations, or EPOs, are similar to PPOs in their organization and purpose, but unlike PPOs, they limit their beneficiaries to participating providers for their health services. For example, beneficiaries covered by an EPO are required to receive all of their care covered services from providers that participate in the EPO, similar to an HMO. Point of service plans, or POS. Many HMOs offer an indemnity type of option known as a POS plan. The primary care doctors in a POS plan usually make referrals to other providers in the plan, but in a POS plan, members can refer themselves outside the plan and still get some of the expenses covered. If the doctor makes a referral out of the network, the plan pays all or most of the bill. If the patient wants to use a provider outside of the network and the service is covered by the plan, the patient will have a higher out-of-pocket or co-insurance responsibility. Medicare Advantage plans. Medicare Advantage plans are health plan options that are part of the Medicare program. A patient must have both Medicare Part A and B benefits to be eligible for a Medicare Advantage plan. The patient continues to pay his or her monthly Part B premium to Medicare. And in addition, the patient may have to pay a premium to the Medicare Advantage plan for the extra benefits that they are obtaining, which can include prescription drug coverage. Patients who join a Medicare Advantage plan generally get all of their Medicare covered healthcare through the plan. Medicare Advantage plans include the following types of plans: a Medicare Health Maintenance Organization, or an HMO. They also have the preferred provider organizations, or PPOs, private fee-for-schedule plans, and Medicare Special Need plans. Medicare Advantage plans replace Medicare's traditional fee-for-service plans. Patients who join a Medicare Advantage plan will receive a health insurance card from the plan they select, and this card must be used to access healthcare instead of their Medicare card. Most plans provide extra benefits and lower out-of-pocket amounts than the original Medicare plan, but with some plans like HMOs, the patient may be required to see doctors who belong to that network or to that plan, or go to certain hospitals to receive services that will be covered. Medicaid HMO plans. In many states, people covered under the Medicaid program are required to join managed care plans. Medicaid managed care plans focus on preventative health care and providing enrollees with a medical home for themselves and their dependents. Medicaid managed care plans must ensure the recipients have access to all medically necessary services that are covered by Medicaid, but use the HMO managed concepts to coordinate care for utilization management. Capitation is a method of payment to healthcare providers whereby a fixed amount is paid per enrollee or per patient to cover a defined set of services, such as physician visits, routine diagnostic testing, etc., over a specified period of time, regardless of the actual services provided. So it's one fee, whether they provide a little bit of service or a lot of different services. Consumer-directed health plans, which is a CDHP. With a consumer-directed health plan, the subscriber agrees to a high initial deductible, typically in the $2,000 to $5,000 range, in return for lower premiums. In addition, these plans are typically attached to a health savings plan, which allows the employee to save pre-tax dollars in an account that can be used to pay for the higher deductible and co-insurance liabilities. An advantage of these accounts is that there is no requirement to spend the funds within a given calendar year, and any remaining funds go with the employee should the employee leave the current employer. Specific managed care requirements. The various tools and how they're used to manage utilization are listed here on this slide. Pre-certification or pre-authorization routinely required for elective hospital admissions. So concurrent reviews can be planned and discharge planning can be started on high dollar outpatient services, including surgery, to monitor and or control utilization by evaluating the appropriateness, necessity, and quality of the requested services. Referrals is a document completed by a primary care physician that notifies an HMO insurance plan that he or she is sending a patient to a subspecialist or specialist for medical care beyond the scope of the primary care physician. The referral notifies the insurance that the primary care physician has recommended and is coordinating this care. Notification is a requirement whereby providers notify the insurance plan that an insured patient is requesting medical services. Insurance companies usually require notification so that their case management can provide utilization management services as required. Days approval, continued stay review, and additional days of approval. Typically, a utilization review nurse is assigned to a case or to a patient, and based on the admission diagnosis and clinical data, the managed care health plan authorizes a length of stay and will not pay for services beyond the approved days unless additional days are authorized. Site of service limitations. Many health plans have developed care plans for common diseases and procedures. The care plans will include appropriate setting for the care and will only pay the services if in an approved setting. An example would be that certain surgical procedures will only be paid as outpatient. For example, colonoscopy or a cataract eye surgery. And then a few points to review in this section. Managed care plans have agreements with physicians, hospitals, and other healthcare providers to offer a range of services to the plan members at a reduced cost. And the managed care plans include all of those listed on the slide. Additionally, managed care health plans use prior authorization and utilization management review to determine if care is medically necessary. These procedures and tools include pre-certifications or pre-authorizations, referrals, notification, site of service limitations, case management, and discharge planning. And this brings us to a polling question. Which option is not a specific managed care requirement? One more minute. Right, and we'll go ahead and close the poll. So the results were a little divided on this one. We had we had choices from A through D. So I'll just jump into the correct answer, which was C. Preferred provider organizations, or PPOs, are a form of managed care, which is the closest to an indemnity plan. PPO is not a specific managed care requirement. It is a health plan where the employer and the health plan contract to purchase healthcare services for covered beneficiaries from a selected group of participating providers. And now we're going to move on to section 2.6, which is price transparency. And in this section, we're going to cover the principles of price transparency, the role of price estimates in patient financial care and how pricing information is used to prepare and present price estimates. So what is price transparency? Getting to the price is a challenge for both patients and providers. Price is defined as the amount actually paid by the health plan and or the patient for a specific service. This is very different from either cost or charges. The price a patient pays for healthcare services depends on the healthcare insurance that he or she is enrolled in, or if they don't have insurance. If a patient has health insurance, generally the patient shares in the total price in the form of a deductible, a copayment, or a coinsurance. In addition, health plans often contract with hospitals, physicians, and other healthcare providers to form a provider network for its subscribers. The price for in-network services will be lower than the price for the same services at an out-of-network setting. With high deductible plans, consumers and patients are requesting price and quality information as part of determining where they will receive the care. And of course, that's because their out-of-pocket is going to be higher. Therefore, providers have developed a process and employ technology solutions to respond to these requests. The first component of a pricing determination is a verification of the patient's insurance eligibility and benefits. Most often, this information is obtained through a real-time electronic transaction with the health plan. The second component of determining a price is to identify the service or test involved. The clinical information is needed to determine a price, including the specific service or test, the patient type, diagnosis and procedure codes, and any anticipated follow-up care. The health plan response to a verification inquiry typically consists of the following information, which is needed to develop a price estimate: a confirmation of the consumer or patient's eligibility for coverage, details of coverage and limitations, including site or services restrictions, such as eligible lab draw stations or the number of therapy visits maximum, network status, authorization or referral requirements, and detailed status of contracted deductible, copayment, coinsurance, and maximum out-of-pocket limitations. Your organization may have developed or deployed a technology solution to create price estimates. If not, you may have a worksheet or other tools to guide you through determining the information needed to respond to a price estimate request. Typically, we verify insurance coverage so that we can determine eligibility and benefits, and then we document the current status of the deductible and any coinsurance amount. We identify the contract terms between the organization and the health plan. For example, if the patient is responsible for a percent of charges or a preset case rate or a bundled service, etc. And then we obtain the total charges for the hospital portion of the case, concurrently identifying any additional provider who may be involved, such as anesthesia, and note in their in-network and out-of-network status. Next, you'll need to apply the benefit information to the charge information, apply the payment methodology to the total charges, and the price estimate should be presented in a format that's easily explained to the patient. In addition to the price estimate for hospital services, the financial conservation should also inform the patient that physician services are or are not included depending on that particular estimate. The in-network or out-of-network status of the physicians should also be communicated, as that could impact the price. On this slide, we have a few key points as we wrap up this section. It's important to apply price transparency principles to the development of information necessary to successfully complete a financial responsibility with the patient. While healthcare is different from commodity purchases, consumers do expect that providers will inform them of their responsibility for the service. And coupling the price estimates with patient financial communications are the best practices that allows providers to provide a high quality level of financial care to patients. And this brings us to a polling question. What is the first component of a pricing determination? All right, we'll wrap up. Everyone answers, so we'll wrap up. And I think the group is torn between A and B. The correct answer is B. Most often, this information is obtained through a real-time electronic transaction with the health plan. The health plan response to a verification inquiry typically contains the following information, which is needed to develop a price estimate: a confirmation of the patient's eligibility of coverage, details of coverage limitations, including site of service, restrictions such as we use the example of draw stations for lab, or the number of therapies that they will have throughout a calendar year, visit authorizations, and a network status. That brings us to section 2.7. In this section, we're going to address the patient financial communications best practices through concepts of financial counseling, patient financial care concepts, which include negotiating account resolution, identifying and initiating financial assistance processes, such as charity, and pursuing time of service collections and achieving account resolution. So financial counseling is done to help the patient understand his or her healthcare plan coverage and financial responsibility. Components of financial counseling include informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient so that appropriate resolution can be found to the financial obligation. Patients' liabilities are comprised of two types of self-pay dollars. One type is pure self-pay, where the patient is uninsured and is responsible for the total cost of the healthcare services. And the second type is the self-pay balance after the insurance pays their portion. These amounts are the cost the patient is responsible for, which is determined by employers and health plans and includes plan deductibles, co-insurances, co-payments, and any non-covered services as identified by the health plan or the employer. Patient financial communication best practices developed by an HFMA task force of industry leaders addresses patient communications regarding health plan coverage, financial counseling, financial responsibility for service, and unpaid balances. A complete copy of these best practices can be found in the resources tab of this program on our website. They also address the most appropriate ways to conduct financial interactions at every point in the patient-centric revenue cycle, from the moment an emergency or non-emergency medical services are scheduled or a patient arrives to a non-scheduled service for elective or non-elective procedures. Compliance guidance is included, as well as annual training requirements, technology assessments, and annual reporting to the C-suite on this topic. So I think that's a really helpful tool some of you may want to look into. So we discussed creating estimates in the last section, and that should provide you with the ability to have a conversation on patient liability, including past due balances. Some options are full payment, a short-term payments, or potentially a bank loan program. If financial resolution cannot be obtained through any of the options provided, then financial assistance screening should be initiated through Medicaid and hospital financial assistance programs. Medicaid eligibility screening may occur through a variety of approaches, all designed to qualify patients for medical assistance. Typical approaches are presumptive eligibility, so depending on some states that might have that Medicaid expansion. Country or state workers maintain an office in the hospital and meet with patients. An outsourcing firm meets with referred patients and helps them complete applications. And internal staff within the patient access department screens the patient's applications based on current medical guidelines and refers cases that qualify or are borderline eligible to the local Medicaid office for processing. Financial assistance is offered when the responsible party does not have the ability to pay and does not qualify for Medicaid assistance. This is often based on a sliding scale discount amount of up to 100% discount based on the patient's financial status. Each provider determines the amount of the discounted or free care. However, the basis for qualification is typically the federal poverty guidelines published annually by the federal government. Each provider must comply with the rules included in the Affordable Care Act. Financial assistance representatives represents an account resolution option which must be managed within the guidelines set by the provider. Communicating effectively with patients can be complicated by the negative implication of the use of the term charity. Presenting financial options and provider-based assistance opens a dialogue without the negative effect of the charity term. Patients who are either uninsured or underinsured are screened for potential financial assistance. The provider's financial assistance policy and application are presented to the patient. The financial counselor may assist the patient with the application. Information requested typically includes 4 categories of information, which is demographic, income, assets, and expenses. Part of a successful time of service collection program involves training staff on how to request payment and conduct the conversations in a way that minimizes barriers to payment. Scripts are an effective staff tool that provides guidance on how to conduct the interview, ask for payment, and overcome payment obstacles. And I can personally tell you that scripting has really assisted my team through the years. We have found that anticipating when a patient's not going to be able to pay and how, and kind of training the staff on responses to overcome those negative responses has proven to be very helpful. So this brings us to the end of our section, and key points that are very important are components of financial education include informing the patients of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient. The financial component of financial counseling is obtaining financial resolution. This brings us to our very last polling question, which is, what is the purpose of financial counseling? I'll give everyone a couple of minutes since the answers are kind of long. Okay, we'll go ahead and wrap up. And not only did every single one of you reply or answer the question, but everyone got the correct answer. The correct answer is C. Components of financial education include informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, addressing or assessing the patient's ability to pay, and reviewing payment alternatives with the patient. So great job, everyone. This brings us to the end of today's session. So I'll go ahead and open it up to questions. If anyone has any questions, please turn on your camera and unmute yourself and feel free to ask. All right, it doesn't appear that we have any questions. So we'll go ahead and wrap up today's session. Thank you very much for attending. I encourage you to please continue with the online coursework and attend future sessions as all the practice that you can get is very, very helpful for your test. Thank you again for joining and have a great rest of your day.